everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Midwifery Business Consultation. This next section has to do with medical charting and documentation tips. Legal disclaimer we put at the beginning of all of our videos. This is for information purposes only. Content is not intended to be substituted for professional legal clinical advice. We try to keep our information as timely and accurate as possible, but we make no claims and guarantees and disclaim liability for error and omissions. The course objectives. The students will be able to verbalize why this topic is important. Why is it important to learn about how to document, how to chart, for multiple reasons. You'll be able to explain exactly what it is, the benefits of the medical charting, the purpose of it, the information you would should include on a medical chart, what you shouldn't include on a medical chart, and then verbalize the different ways to access the medical charts, particularly with HIPAA compliance and the EHR systems that are out there. Students will be able to verbalize what are the different options for the electronic medical records. They'll be able to see how it's a very helpful tool in documenting. There's templates and being careful with common documentation errors that we'll be going over. And then just the last summary of what are some general medical charting and documentation tips. So why is this essential? It's important for us to have accurate documentation for multiple reasons. It is a story about your clinical decision making, the assessment, the plan of care, the concerns the client had, why they were seen, what's going on. It's used to communicate with your providers within the staff. It's used to communicate with a referral, a specialist, a transfer to a hospital. There's many purposes of your clinical records. The other one is it's a legal defense for you if you're ever sued. It tells a story. It tells your decision making. Hindsight is 20/20. If something happens in a bad outcome, they're going to look and see, was there anything missed in your assessment, your plan of care, your management that could have prevented that bad outcome, or was it just something that was going to happen? You did do everything appropriate. It's essential to keep your records. Some midwives providers still do paper charting. Many states you need to keep it up to 18 years depending on the statute of limitations in your area, because a lot of things with birth, there's a longer extension because of the newborn development, the child development, early years, preschool. If they say this kid's a little slower in school and it could be linked to some birth outcomes, they still in many states can seek litigation, and you need those documentation to support yourself. It's a big stressor. If you didn't chart it, you didn't do it. It doesn't matter how much you say, I did this, I did that, if you didn't spend the time charting it. And that's one thing I noticed very different about nurse midwives or certified professional midwives that had a background in labor and delivery, had a background in more high risk NICU, PEDS, PICU. They document really, really thoroughly because that's how they've been trained. It's a high risk litigation environment in obstetrics. And then people that tend to be more out of hospital private practice, never really exposed to that style of charting, tend to not be as thorough and as detailed. So it's always important to chart. You repositioned them. I mean, some things I think midwives do so automatically. We just think, I don't need to chart that. I know this baby's doing fine because of XYZ. There's fetal movement, there's clear fluid, there's acceleration with the Doppler. Those are important things to chart. We want to note, why did you think there was reassuring signs? Why did you think there was concerning signs? There's so much in our minds we're doing that it's a little overwhelming to chart. Charting is not our favorite thing as midwives, but it's so important. Improper documentation can open up an employer, a provider, a midwife to massive liability issues. Informed consent is another big area. If they're choosing to do something, you really want to have a procedure consent they sign. You want to have a detailed risk benefit summary that you talked about with them, particularly like with twins, breech, VBAC, something that's a little more higher risk of litigation. You really want to be thorough in your documentation of conversations, near misses. You talk to your consulting physician, the client declined the recommended plan of care. You need to really stress and put because it's about what does the client want. If you give all the options, you need to make sure you're documenting all the options we're given. So what exactly is a medical chart? Let's just go back to the basics. A medical chart can be a piece of paper, can be an electronic medical record. It's pretty much telling the data, the medical history, the reason for the visit, the assessment, the plan of care, the follow-up recommendations, their vital signs, the physical examination, allergies, lab results, immunizations, who you consulted with, informed consent. It has all the details. So when we do maternity care and we build a relationship, we see them multiple times, and there's certain key educational topics we talk about at an initial OB visit, at 20 weeks gestation, the ultrasound, 28 weeks gestation, we talk about RH incompatibility and ROGAM and fetal kit counts and signs of concerns. Like, there's so much education and counseling that midwives do that a lot of times in our charting we just don't give ourselves credit for. Particularly with billing, medical charts are really important. We do so much quality as birth professionals that you want to put the amount of time you spent with a client. A traditional medical practice spends 5-10 minutes for a return obstetrical visit. A midwife spends closer to 30 minutes to an hour because of the counseling. So if you're billing and you're putting additional time, additional complexity, you screened for this, you did this extra test while they were with you, you have to document it. So then if you are billing insurance companies and get audited, it's the same concept. If you didn't chart it, you don't get paid for it. So I think there's so much financial loss of value we do because as midwives, we just don't know there's a code that's involved with that. We didn't know exactly how to chart to give credit for it. So many things that we're doing. So the other thing to think about is a medical record can be used to review history from last time they were there. Maybe they're here for a well woman visit and haven't seen you in a long time, or you just seen them last week and they're getting close to delivery. You want to have an easy record that anyone on your team can look at things. If they call for a lab result, they call for a question, you want your nurse, your medical assistant to be thoroughly understanding, why did you order that lab? What was your plan of care if it was normal? What was your plan of care if it was abnormal? They need some medications ordered. You're going to verify their allergies and make sure that there's no safety concerns. If you're doing more primary care services, you can review their immunization or send them to the health department to get their Tdap, their flu shot, their COVID vaccination. So there's just really important pieces to make sure we're being very thorough while we're taking care of people. It's not just treating the problem that's in front of us or educating them about the stage of pregnancy they're in. It's also reviewing all these things every single visit because you don't want to miss anything in their pre-existing conditions, chronic infections, new onset asthma. You want to make sure you're documenting that new diagnosis so the next person taken care of, or if she calls with an asthma attack in a few days, there's a history, there's an understanding of where the baseline has been at. So the benefits of medical charting, it ensures patient safety through a thorough and complete documentation. I think sometimes without a hospital and primarily serving low-risk healthy mothers in birth, we tend to be a little more lax with our charting because we're like, well, she's normal, she's healthy. Well, we need to chart those things. We talked about fetal movement, we asked her about vaginal bleeding, we asked her about contractions, we asked emotionally how she's doing, is there any fears, is there any anxieties, what's her educational level like, is she a first-time mom? Has she had 6 children before? Common topics, we want to talk about breastfeeding, we want to talk about circumcision, we want to talk about a birth plan. We want to make sure all these things during a visit is being documented. I joked all the time, and a lot of providers and specialties actually do this, like having a personal assistant follow you around and document everything you're doing, or just recording directly our conversation, and that's my medical record, because we dread as midwives and healthcare professionals to chart. It's time consuming, it's overwhelming, we want to just see clients. It's not the fun part of our services, but it's definitely one of the most important parts for many, many reasons. It improves the quality of care, the continuity of care, collaborations, better communication, because there's many people involved taking care of mothers and babies. We've got the pediatrician, we've got family practice doing primary care things, we've got obstetricians if there's concerns, we've got maternal fetal medicine, we've got the transferring hospital labor and delivery nurse manager that wants to have records, the charge nurse at that time. We want to make sure that we're giving all the information thoroughly in a concise way. We don't want scattered thinking. We don't want to all of a sudden tell her plan of care and then put her concern a visit. SBAR is a great reference acronym to use for charting situation, background, assessment, recommendations. That's a great way to communicate with people. It's a great way to chart. Another great acronym to use for charting is SOAP, situation, subjective assessment, objective assessment, and the plan of care. So you're wanting to take these steps and follow them from beginning to the end. Why did they come see you? What are the things that they're concerned about? Asking great questions. If they're having pain, where it's at, how long has it been going on? Is it getting better or worse? What makes it better? What makes it worse? You want to really thoroughly assess every single concern that they're having. And then what did you do to assess? Did you order some labs? Did you order an ultrasound? Did you do a physical assessment? Did you do additional counseling because of that concern? And then what is the follow-up plan? No follow-up plan necessary. Follow up in a week, watch for lab results, review education questions next visit. You just really have to think thoroughly of everything we're doing, giving credit for. So typical information included in a medical chart, it'll have the demographics, it'll have their name, date of birth, contact information, their health history. If it's peds, newborn, they can have growth charts, developmental scores, cognitive, but a lot of times for us, we take care of women during pregnancy, so that would be like the fundal height, that would be the trends of measuring baby, ultrasound, growth, those things. Immunization records, we just want to review at the appropriate times, flu vaccinations, COVID during different timings, the boosters, ROGAM, and the Tdap are common ones discussed. And depending if they're traveling outside the country, you may have some additional vaccinations to discuss with them. Medications they're currently taking, and that includes not just prescription, it's over the counter, and also alternative therapies, supplements, essential oils. They're all really important to include. Medical allergies, if they don't have any, you can put no known medical allergies. If they have an allergy, it's really important to put what is the side effect. Was it a childhood allergy? Was it a severe anaphylactic reaction, or was it just a little bit of itching? You may be able to give them some Benadryl if it becomes a risk benefit that you consider giving them a certain medication. So it's important to know how severe the allergy is on top of what it is. So other things you want to list, have they had surgeries before, particularly with us doing obstetrics GYN, we want to know about pelvic surgeries, especially heart surgeries. If they've had C-sections before, if they've had PCOS, if they've had any obstetrical history concerns, how many pregnancies total, how many miscarriages, any complications with them, were they term, normal, healthy deliveries, were they always post-dates, were they always preterm labors? Because if she has risk factors based on her history, we're going to do additional monitoring, additional recommendations. So for example, frequent history of preterm labor, we're probably going to talk about progesterone. Maybe she would be a good candidate for a cerclage, depending on what the reasonings for that preterm labor were. You'd be consulting your OB just to double check, is there anything I'm missing on my recommendations? Because it is a little more of a high risk situation, and it would warrant just a little more expertise involved. Family history. That's really important with what we take care of with our women. Did they have a baby with Down syndrome before? Have they had a stillbirth? Have they had extensive heart conditions in their family? Extensive diabetes? She's a higher chance of gestational diabetes. Cardiovascular concerns. You definitely want to, because they're risk factors, they're educational opportunities. Social history. What does she do for a living? Is she on her feet being a waitress all the time? Is she a stay-at-home mom and there's 5 young kids at home? She's probably going to have more discomforts with aches and pains and back and hip than the average woman. So it may be a great idea to have a conversation of an abdominal support binder for her. What does she have for community support? Are they in town because her partner is in the military and there's no family around? Does she live in her hometown where her mom's across the street and she has lots of great support? These are important things to know when considering a birth setting, considering risk of postpartum depression and safety, like with abuse and neglect. And we want to make sure that she's in a good situation, she's happy, she doesn't have depression. We want to really cover all social aspects. Habits are important. How's the sleep she's getting? How's she exercising? Any history of alcohol abuse, drug abuse, sexual history? We don't ever want to make assumptions of their orientations, their preferences, their beliefs. And so it's great to build that relationship and trust. And I think midwives are really, really good at that. Our clients open up to us. They trust us. We get more time with them. We get more education. So we, compared to the average healthcare providers in the United States, get much more thorough discussions with the social history education, but many times we just don't give credit and document. So who has access to the medical chart? That's a really important thing to think about. It would be the healthcare provider, their staff, they've reviewed HIPAA. They're not going to talk to the community about this client. They're only going to discuss things that are pertinent, medically related. They can talk to collaborating physicians, providers when it's medically pertinent. The patient has right access to their chart if they want it, and then they have permission given in writing if they would like anyone else to be able to see their chart, their lab results, their husband, their partner, their mom, their sibling, whatever it is. So we have to be careful when we get phone calls that we've got to verify. Like if the client says, hey, I'm Jane Smith, I'd like to know my lab results, you need to ask some further questions. What's your date of birth? What's your address? What are some pertinent medical things that only she would know to be able to confirm that's her? And then if they say, hey, I'm Jane Smith's husband and she can't talk right now and ask for me to call about this result, you have to double check, does Jane's husband have access based on her permission to release medical records to? And then you take step by step asking some pertinent information about her to verify, and then you'd be able to give the information. So you want to make sure your information is accurate. You want to chart things objectively because your client with patient portals will have access to the medical records. So you don't want to complain, you don't want to put negatives, you just want to be objective to the point. Client called with this concern, we talked about the options, she declined the plan of care, versus the patient's disgruntled, she complained all the time, I told her what to do and she is just doing her own thing. That looks very, very different and it's not professional and credible. So we really want to, non-compliance is a hard word we really try not to use because there's a lot of barriers. There's transportation barriers, there's cultural barriers, there's people having the right to choose motivation, like especially people, I see it all the time, will put non-compliant with managing diabetes, non-compliant with obesity, but they're worrying about where they're going to live. And with the Maslow's hierarchy of needs, we have to support their basic survival needs before they are even motivated to take care of themselves better. So it's our responsibility as healthcare providers to really document well, get a good sense of where they're at, what are their needs, and what can we help with at this point in time. So what exactly is an EHR? It's an electronic health record, and most systems use this nowadays. There's a few that still do paper. There's a lot of great systems out there for midwives. There's Midwife, Mobile Midwife, Midwife Maternity Hood. There's so many great ones. I like Athena Health if someone is doing more insurance and GYN and a full encompassing large scale practice, but there's dozens and dozens of ones out there, and they each have their pros and cons. So you just have to do a really good job when you are the provider considering adding an EHR to your practice. What are you looking for? Do you want the reports? Do you want the patient compatibility? Do you want labs to sync? Do you want billing to be part of the service? Do you want just basic forms? What's the price? Is it commission based? Is it a flat rate per provider? What are you looking for out of your EHR? And then the side of when you're documenting and charting, is it an easy flow from check-in to check-out? Is it easy to find things in their records versus you're digging and digging and you don't know exactly where to find something even though you know it's there? So you want to make sure your records are as accurate as possible, as real-time as possible to chart. So I encourage providers, as soon as they're done seeing the patient or while they're in front of the patient, chart. It is always hard to have an art of giving full attention and looking at someone and versus just typing. It feels like you're not fully attentive. So a lot of midwives will just take high-level notes on a piece of paper, the stats, the common concerns, and then before seeing the next client, they will chart really quickly. And once you get good at it and you've got good templates, it'll take you 3 minutes to chart a routine OB unless there's something complicated going on. And maybe it makes more sense to just chart after you talk to the collaborating physician and you have a full plan in place. So it's important to share information securely for the entire care team, everyone in your office staff, on top of anyone you collaborate with. Some of the systems have EHR compatibility with other practices, particularly Athena. If someone else you collaborate with has Athena, you can send records instead of by fax and giving them permission. So there's a lot of amazing tools out there, and you just have to look at the pros and cons of what you're looking for with your EHR system. So it's something that shares medical information between the providers and other healthcare professionals. It's lab results, images, emergency visits. Schools can have access to it, pharmacy for prescription authority, and it gives a clear history of what you want. I mean, sending prescription is so easy, and very few places as pharmacies are now taking paper, phone prescriptions. If you want to be a practitioner that regularly prescribes medications for your clients, you're going to have to be compatible with the prescription access portal. So how does the EHR system help? It reduces medical errors. It helps with a lot of practitioners just have poor penmanship. They're not very good writers. We always joke it's the doctor's signature. Oh, you were meant to be a doctor, because it's fast and sloppy and nobody can read it. So a lot of med errors are made because people would read it and it would be the wrong dosage, it would be the wrong frequency because they couldn't read. So there's definitely improvements in medical errors because it's typed. You can't have a misinterpretation. Sometimes the system will even flag autocorrect, like, you spelled this wrong, is this really what you wanted? So there's definitely improved accuracy and clarity with the communication among teams. When something is ordered, there's no discrepancy on misunderstanding handwriting. It's a great way to guarantee medical records are never lost. I can tell you so many times of transports, and we had multiple offices, we did home visits, and when you had paper, it made you a little nervous, because if all of a sudden they dropped it in the water when they were going to a visit and it's pouring and raining and the papers are all wet, or you had a stressful transfer and they want records, you were tired, exhausted, you thought you made a copy of them and then you can't find them. There's a lot with having an EHR system. It's stored online, it's stored in their program, it's an electronic database. If you ever close that EHR system, you get digital records of everything, versus you have to keep a big filing cabinet for many, many years after your practice closes or you transition. I know so many midwives in retirement, they just had so much paper records that they had to store for a long time, versus getting it all scanned using an EHR from the beginning. It's just so much easier. Common documentation errors: medication and allergy omissions, forgetting to ask them about a medication, or not thoroughly saying, hey, has anything changed, actually going over their medications, because it's really easy for clients to say, oh yeah, nothing's changed, but then they forgot. They're busy moms and they forgot they went to their primary care and got started on XYZ. So you want to review their allergies each and every time. You want to review medications. Just ask them specifically, leave it open-ended. Do you have any allergies? Do you have any medications you're taking at this time? And just double check the list and see if something's outdated, if something needs, especially an initial OB visit, if they haven't seen your practice in a while, you want to be really thorough with the history. If there's symptoms, if there's concerns, there's complaints, you want to be as detailed as possible. You want to find out what they're taking, how long they've been taking it, could it be a potential side effect, something new they're doing that could cause aggregating symptoms, pain, discomfort. Is it just normal towards the end of pregnancy, or is it something truly concerning that needs a further evaluation? You want to talk about any meds, the dosage, if they had a side effect, just going into details what the reaction is for the allergies. And then being careful with, like, if they have an allergy to penicillin, you don't want to take another antibiotic from the similar family. And the cool thing is with these EHR systems, they tend to flag if you have an allergy listed and you're trying to prescribe a medication, they're going to tell you it's in the same family class. We don't recommend you prescribe it. Here's another one. Or, there's somewhat of a compatibility issue they found in data. Like, there's some better recommended medications for that treatment based on their history and their allergies. Common documentation errors, like leaving blanks on chart, crossing things out, white out. It looks a little odd. It looks a little ambiguous. It makes them think, did you forget to chart something? Why is this gap here? Was something missing? It's a pretty significant thing. Patients sue if the treatment wasn't documented, and if you have a blank that you said you'd go back to later, You just have to be very thorough with your documentation, have consistent systems of how you're always going to document. Are you going to always be real time? Are you always going to document at the end of the day? I don't encourage that, because you'll sit there for an hour, hour and a half, and then all your ladies' data and conversations will mix together, and you'll start charting on one lady what you did for another one. So I do encourage real-time charting if possible. Unclear orders: if you weren't specific enough in what you wanted, you didn't put a diagnosis, you didn't put how often, how many refills, how many meds to take, you want to make sure your orders, your recommendations are as clear as possible, because it takes extra time for a radiologist, ultrasound department to call you back to clarify an order, the pharmacist to call you back and clarify an order. So it's definitely being respectful of our colleagues and our own staff, and it's a safety concern. So you don't want to leave any guesswork. You don't want them to assume you want something else, and maybe this is a unique situation, and that just increases safety concerns. The do's and don'ts of documentation: before entering anything, make sure you're in the correct patient chart. I can tell you how many times I was tired, exhausted. I have 4 tabs open for people charting, and I thought I went to the right one, and then I get my note all done, and then I realize, crap, I charted it on the wrong person. So then I have to copy that, paste it, and then I have to put a remove and then an addendum and explain it was a patient mistake, wrong person. So there's just extra steps you have to do when you accidentally chart on the wrong person. And if you don't catch it, then there's another concern that now you're giving recommended plans of care and assessments for the totally wrong person, and that's a big, big deal. So you want to be thorough. You want to make sure you're on the right chart. A lot of EHRs, you have to make sure you're on the right encounter for today's visits versus a year ago versus the ER, because some things will get disabled in your system, and you want to make sure that the charting is linked to the right encounter for billing, for reviewing later, charting any meds you gave, the location, especially postpartum. There is so much happening with mom and baby that I think that's the biggest time when charting gets a challenge, because there's so much happening, and it's 2 in the morning, you've been labor supporting her for 24 hours, you're tired, exhausted, you just want to go home. That's where I notice that postpartum recovery, that the most lax charting occurs. Record any phone conversations you have with the patient, you have with the physician, talking in detail what was the exact time, what was the message, what was the recommendations, the response, the plan of care, and being thorough. Because I think sometimes when we triage a patient at 3, 4 in the morning, we're like, oh, that was a minor thing, I just don't want to document it. But then maybe there was a bad outcome because of the recommendations you gave, and if you don't have any documentation to defend you, it's very hard. So there's times where we take it for granted that triaging a patient, anything you do, any conversation, you want to make sure you're being HIPAA compliant and you're documenting everything. So text and email are not recommended for communication with your clients. Use the patient portal, use a phone conversation, because you want to make sure you're keeping their personal information safe. If something needs to be added to the documentation later, always make sure it's an addendum and you're writing the late entry date and time. There's nothing wrong with that. You just have to be careful that, especially with hand charting, it's a little deceptive. Like, you could easily just put, well, today is 2 days later, but I could just write the time. Oh, I did one more thing before I left her house after the home birth. But in electronic systems, it knows exactly automatically for you when the data entry was. So I think it's more for paper charting. You just have to be really careful, and the longer you wait to chart something, the more suspicious it looks you're trying to cover your butt. So that's why it's really important to do real-time charting. If all of a sudden the next shift you just remembered, crap, I forgot to chart that, you put it in there. It's better to put it in there. But if there's a bad outcome, you want to make sure you spend the time documenting as soon as the patient is taken care of safely, to be a very thorough documentation in real time as possible. Don't chart symptoms such as concern of pain. You want to make sure that you go in details. What is the pain like? Concern of a sharp shooting discomfort in the left lower quadrant. Pain is a very vague term. You want to make sure that you're charting, okay, there is a concern of XYZ symptom. You made sure you addressed it in some shape or form. They told you they were having pain, but then the rest of the note shows nothing you did about it. That doesn't look very good. Maybe you actually did talk to him. Maybe you did make a plan of care, you reviewed comfort measures, but if you don't chart it, and especially if it turns into something more serious, complicated later, we take for granted sometimes when it's a normal pregnancy discomfort from our assessment. We need to document that. We need to give credit. And then we have no rights to ever alter a patient's record. It's a criminal offense if you're trying to sign for someone, you're trying to change the history, you're trying to change the conversation, maybe not putting truthful things down there just because you want to protect yourself. I mean, that is a very serious fraudulent offense. So always be accurate, always use medically approved abbreviations. If you're paper charting, make sure your handwriting is clear. EHRs will have a lot of great tools and templates, and make sure you're being as specific as possible. Don't just say a large amount of bleeding. Estimate the best of your ability, saying she had 3 clots, estimated all of them were around 50 cc's, 30 cc's. Wait if you can weigh, which I know is sometimes hard when you're in an out of hospital setting and there's limited resources. It's usually the midwife and the birth assistant. But during labor and postpartum, if you can keep the pads and you can weigh them later and say, okay, the total postpartum hemorrhage was 1,000, 1,200, whatever, you're much more accurate and it holds up stronger in court and credibility. It's more objective. So the more objective we can get with our data, the better, particularly with postpartum hemorrhages. We just don't want to say a small amount. Is it a dime size? Is it a quarter? Is it bright red blood? Is it old? Is it clot? Is it a steady flow? Like, being as descriptive as possible is really helpful to determine what's the management steps. If there's a lot of clots, you always worry if and that's what's causing the uterine atony, that if you need to do a manual expression versus her uterus is nice and firm and she's got a bright red steady flow, you're going to be looking for lacerations, a cervical tear. So you want to put thoroughly how your assessment determined the plan of care, and so that they correlate together. Medication not administered because it wasn't available. Medication not administered because patient's non-compliant. Never chart what you heard or express feelings, emotion. You want to keep it objective and to the point. And if the patient says something, you quote them directly, word to word. I think no one is listening to me. I am going to do an unassisted birth because I don't trust the hospital. I don't trust you anymore. You want to put word for word what is the patient saying to you. Never chart ahead of time. Things can change. It looks suspicious because then they start thinking you're automated and, well, how did you know she had this normal vital signs? How did you know she was coming in that day? Like, you want to be, and sometimes it's a convenient thing. I see midwives all the time will come in at the beginning of the day to try to get charted and templates ready for their clients, but then someone doesn't show up and then they have to void it, or something changed but then they forgot to update it on that record. It doesn't, the best thing you can do is chart in real time, the best of your ability if you're talented and skilled to type and give full attention to the client. Otherwise, just chart immediately after the visit. Well, while it's charting, it may seem menial and repetitive. It requires a lot of time. It does, but to get great outcomes and to reduce your risk of liability and malpractice suits, you want to thoroughly chart well. You want to be able to give high quality care. And things seem repetitive to us. We're like, okay, I've written she's had good fetal movement every single time. I've written this number every single time. I've written she has known allergies every single time. But it's important to show you addressed it and that you talked about these things, because you never know when it's going to make a difference for continuity of care or for protecting yourself, that this is the conversation, this is the decision the client had made. So medical charting tips, you want to hone in on your typing skills. If it's an EHR system, you want to be fast and clear, and a really important skill, details, details, details. I can't stress that enough to people. You want to be as objective as you possibly can. Subjective, tell all the concerns, questions, all the stuff that's going on in her life, physically, emotionally, goals she has, because it's really important for us to take care of our clients with a full scope mindset, mind, body, and soul. Clear and to the point. We don't want to write full paragraphs. You want to put, she's having trouble getting to the bathroom. She has incontinence with sneezing. She has pain when she bends over quickly. Like, you just want to be to the point and say what it is. You don't want to be fluffy, extra stories. We're not writing a book, we're writing a medical chart. You want to know what you're talking about. You want to have the best evidence. You don't want to make stuff up. You just tell the client, well, I'm going to do some research and I will follow up with you. Or, okay, I just read about this. I just went to a conference. This is the recommended standard of care. Here's the options. But if it's something you haven't dealt with, it's a new diagnosis, it's a new concern that you're like, I have no idea what could cause this. This is the first time I'm in front of this. You want to just put your plan of care is to do some initial labs, do some research, follow up with the client, and review some warning signs to call you or to go to the urgent care for. You want to be honest. You want to be truthful about policy, standards, scope of practice, what you can and can't offer. I think midwives, we want everyone to have a normal birth, and we want to take care of so many ladies that I think sometimes we leave, not intentionally, what is our full scope? What is a low-risk healthy care provider? What do we do in rare situations? Because so many women, the emotions towards the end of pregnancy get involved where they want a home birth no matter what, and then they go post-dates, they're going into labor a few days earlier, because they're preterm labor, not in that range that's safe to do out of hospital. They're starting to have some vaginal bleeding. That's probably a concern to be at home. You want to make sure you're very truthful, honest, respectful, what services you can offer, what procedures you have skills for, what medications you can give for safety and what you can't in your setting and your skill set. Why are you doing this standard of care? If they have questions, you want to be honest, and you want to, if they're like, are you concerned about my baby right now? And you really are, you don't want to lie to them. They can hear the heartbeat. They can hear you talking to the birth assistant. You want to have a respectful, honest conversation. So you want to learn how to use your EHR system very thoroughly. The functions, the features, the charting software, the reports it has. Everybody on your team will have a different role in your charting system. Your biller will look at different parts of it. The midwife will look at different parts than the nurse or the medical assistant would. So you want to make sure you really are thorough and trained appropriately so that you're utilizing everything and making it as easy as possible. You want to choose the right words. There's many times where I'm like, I can't remember the medical term for this. So I'll put it on a little piece of paper like, what is the medical term for painful sex? And it's dyspareunia. Like, some of these words we don't use very often. It's really important for us to put in the assessment page, take some time to look up the medical definition, the medical condition affiliated with that symptom and what you're thinking about. So it's really important to be as professional and credible. It's a legal document to protect us in the future. You want to be consistent because you can show that in court. Like, I always do a fundal height at this stage, and I always manage postpartum hemorrhages this way. So if something is not documented, at least you have a little bit of consistency to say, every other time I always do Pitocin, then I do Cytotec, and after 3 minutes, if we don't get any uterine atony, I call EMS. Like, to have a consistent flow of how you manage emergencies and high-risk situations is really helpful in legal defense and your memory. If you're tired, exhausted, that autopilot kicks in. Do not copy and paste. It's not an issue with paper charting, but definitely with EHRs. It's easy, it's convenient. Well, everything was the same from her prenatal visit last week, so I'm just going to copy and paste it. You just have a higher chance of missing something that was in that last visit that should have been changed. I've seen medical records where I'm like, she complained about heartburn every single time, and you talk to the client and she's like, I haven't had heartburn in months. Like, it just doesn't look good, because then the legal system will start questioning, well, if you're sloppy with your charting, how are you sloppy with other parts of your care? And so we want to be very careful that we're not just copying and pasting information, because a lot of times there's extra things from prior that we miss and get added that aren't applicable to this visit. Be accurate, avoid late charting as best as possible. Real time is key. Making sure you're clear to the point, you're not missing any of your education, your assessment, your diagnosis, the concerns, the plan of care. Prioritize the legibility. You want to make sure you can read things. It's more with paper charting, making notes to your staff. I mean, even little things like someone called with a concern and your receptionist wrote it down and you couldn't read it. you may have prioritized it a little differently because of what you thought it said, or when you talk to the client, they're kind of laughing because they're like, no, that wasn't my concern. I talked to the receptionist about. So it's not just in the medical chart, but communicating among staff is just important. You want to make sure that we're using on paper charts black and blue ink. You're not going to want to use red. You're not going to want to use highlighters. You're not going to use whiteout. You just put one line through it, and then you put your initials if you need to correct something on paper chart. Make sure you're using the medically approved abbreviations, not your own little abbreviations you did. I found it with a lot of certified professional midwives and more of the apprenticeship model that aren't working as much with the healthcare system and familiar with the terms used. There's a lot of things that they use among their community or themselves because they've been solo. They don't take students. They're doing their own thing. They have a small scale practice that sometimes we'll have conversations where I'm looking at documentation and collaborating and consulting, and they're using things that aren't applicable. In their mind, it meant a perfect acronym, but in the legal, it's not an approved abbreviation. Making sure you document any physician consultations, referrals, services that have been recommended. When did you do it? What was the talk? Especially in emergency situations, when you called EMS, when you arrived in labor and delivery, who you gave report to. Was it the charge nurse? Was it the ER doctor? Was it the peds? Did you recommend the EMS goes to a NICU versus the hospital across the street? Chart symptoms and the treatment plan and follow-up recommendations for it. Be very thorough. You don't want to put hearsays or opinions. Well, the other midwife told me she's a pain in the butt. The other midwife said this. Well, that's not what the client said, and she didn't chart it. And so you just want to talk directly to your patient you're serving, get clear, objective wording, and you're charting facts, not opinions. So just a summary conclusion, medical charts are really, really important. Whether it's paper or EHR, it tells a detailed record of your client's information, medical history, their demographics, their vital signs, their assessment, their concerns, prescriptions, their social history. It gives you a story, and you want to be as thorough as possible. And I notice midwives and nurses and nurse practitioners do much more charting than a typical physician does because of our background and because of the patient bedside care and how we've been acclimated. Physicians tend to not be as good at documenting because they have so much more to do, and maybe the style of how they're taught to document was a little different. There's so many great computerized EHR systems out there, and I'm encouraging most midwives, unless you're serving the Amish low. The patients have rights to their own medical records. You can't refuse that. You got to be careful with HIPAA compliancy, making sure you're not giving information out to the wrong people. Patient portals are excellent to communicate, to share information. It's a secure platform. So you just want to make sure you're verifying the client before you give information out, making sure that they've signed a form that HIPAA released, that they can give medical information to other people they gave permission to. If the patient discovers a mistake, they can ask the physician to fix it. Oh, you put this lab result on my chart and that's not actually mine. You just fix it completely. The midwife just apologizes, and it's an easy move, especially if it didn't cause an additional treatment or recommendation change. You want to make sure you're giving evidence-based care, you're thoroughly charting the information, the educational topics, the recommendations given, what the client decided to do, and what is the follow-up plan. How urgent is something to get taken care of? Negligence is a huge thing that people are sued for, and did you have warning signs, risk factors of something, and you took it as normal, or you waited too long? And so those are things to be really important. Maybe you recommended going to the hospital and transporting because of the vaginal bleeding, but the client declined and stayed home. Like, they are part of the decision making together, but you have to document the conversation story so they can look at it later.